Very warm welcome to a fourth lecture on the dyslipidemia module, and a very warm welcome for a very academic activities that are going on Saturday morning from the Academic Council of Pakistan Cardiac Society. So far, we have covered three topics: dyslipidemia as a risk factor by Howard Kazmi. Sola Siddiqui did a wonderful job as how effective is prevention, and Momin Siddiq did an excellent job in telling us about the nitty-gritty of cholesterol, and it was all very interesting. My topic is rather easy to understand, and that is when to treat and targets. Before we go on to when to treat and targets, this time we have changed the format slightly, and I will show you questions, because last time we realized that many people would not really enter and see the questions. So this time I'm showing you question of power slides. So here it starts. This is the first question. Second question. Please mark it with yourself. Third question. Fourth question. Fifth question. Last question. Right. So the questions that we have in our mind is, how do we determine risk? What is very high, moderate, and low risk? How do you divide and look at different populations? Apparently healthy, those who already have cardiovascular disease, diabetes mellitus, and CKD. When should we intervene? What level we should try to achieve? And what level should we aim for in patients who already have established cardiovascular disease? And I would briefly touch role of therapeutic life changes, which is diet and exercise. So what I get all my data from is from this 2019 ESC/EAS guidelines for the management of dyslipidemias, lipid modification to reduce cardiovascular disease. I would recommend this to everybody. And then in 2021, last year, we had ESC guidelines on cardiovascular disease prevention in clinical practice. And this was endorsed by 12 medical societies. So this is perhaps the latest that we have on dyslipidemia on this issue. The first important message, which I would like to, something that you retain in your mind, is LDL-C. LDL is still the primary target. You know, there was a time when we used to look at total cholesterol, then there was non-HDL cholesterol. Now they say LDL cholesterol is the primary target. And 55 milligram per deciliter is the new target goal for very high risk patients, and we will go over it again. But remember this figure of 55, or if you cannot achieve 55, then a 50% reduction is acceptable for LDL, which ranges from 70 to 136. And it is recommended that in patients who have a high risk or a very high risk for cardiovascular disease, treatment with highest tolerable dose of statin should be started, considered, and used. And if that doesn't work, then azithromycin may be used. And if that doesn't work, then PCSK9 should be considered. For lipid modification in people who have got cardiovascular disease is rather easy. But for primary prevention, all guidelines recommend that we must assess total cardiovascular risk, which means that prevention of ASPD in a given person should be relate to his total risk. So if the risk is high, the more intense the action should be. And if the risk is low, the action should not be intense. And what do we mean by it? And this is perhaps the most important slide or the crux of the talk today. So what is population who's at very high risk? People who have documented coronary artery disease, which means, or atherosclerotic cardiovascular disease, which means everybody who had a previous ACS, MI, or unstable angina, or those who have stable angina, or those who have undergone coronary vascularization, whether it's a PCI or a CABG or other procedures. On the cardiac side, on the brain side, anybody who had a stroke or a TIA, and people with peripheral arterial disease. So anybody who has a documented cardiovascular, cerebrovascular, or peripheral arterial disease. And people who have unequivocally documented cardio disease on imaging, which means significant plaques on coronary angiography or CT angiography, but at least in two vessels and more than 50%, or blockages in the carotid artery on the ultrasound. So those who documented cardiovascular disease or those who have documented cardiovascular disease on imaging. And then diabetes. What sort of diabetes? Those people who have evidence of target organ damage or who have more than 3 major risk factors. So besides diabetes, if they have hypertension, they've got a high cholesterol, they're smokers, so they've got 3 major risk factors, or those who have an early onset of type 1 diabetes, more than 20 years. So 3 conditions that you have to fill: 3 major risk factors, target organ damage, or early onset diabetes. Severe CKD disease, CKD, which is in which the clearance is less than 30 ml per liter, or patients who have got a score higher than 10%, and we will go over this score later on, or those who have got family history of coronary artery disease or another familial history of family or another major risk factors. So people who have got either established evidence of clinical disease or who have disease on imaging will be taken as very high risk category. What is high risk? Now, people who have got single elevated risk factor, which means if the cholesterol is very high, how high? More than 310, and LDL more than 190, or who have got even blood pressure more than 180 millimeters of mercury. So these people who are either hypertensive or have cholesterol also become high risk factors. Those people who have got familial history of hypercholesterolemia are risk factors. Those who have diabetes but without target organ damage, so they go into high risk, and with target organ they go into high risk, very high risk. And diabetes duration more than 10 years. If it's more than 20 years, they're going to very high risk, or those with additional risk factors. Those who have got moderate CKD, which means if their GFR is between 30 and 60, and those who have got a score risk factor risk estimation between 5 and 10. So above 10 is very high risk. What is moderate risk? It is young people, diabetes less than 35 years, more than 35 and less than 50 years of age. Sorry, type 1 diabetes more or less than 35, and type 2 diabetes more than 50 years, with diabetes duration of 10 years without other risk factors. So these people, those who may not have any ischemic heart disease, still are at a higher risk. And if the risk calculated is between 1 and 5%, and low risk is less than 1 for 10 years risk of fatal CVD. And how do we estimate this risk? This is scorecard from ESC, and on this side, it says blood pressure ranging from 120 to 180. Here it says cholesterol level between 150 to 300. So this was an older risk factor where we are not taking LDL, rather taking the whole cholesterol ranging from here. And this is two groups of people, non-smokers versus smokers, women versus men. So it starts from 40, goes up to 65. So let's say in this age group, even if you have a high blood pressure and your cholesterol is high, still you do not come into a very high risk group. Whereas if you go to age 60, so if you have low blood pressure and low cholesterol, you are not into a high risk group. But if you are a non-smoker and your blood pressure is high and your cholesterol is high, which is about 300, you go into as high a risk as 3. And same person, if this person becomes a smoker, it is 13. For a male, for the same sort of a group which has got a high blood pressure, high cholesterol, the risk goes up to 18. And same person, if he smokes as well, that becomes 33. So this is the beauty of this score, that it shows us very nicely. By the way, SCORE stands for Systemic Coronary Risk Estimation. And recently, they have launched a new scorecard. And this says SCORE 2 or SCORE 2 OP, and OP stands for old patient. Here it goes above the age of 70 up to 85, 89. So we'll see in this age group, the risk is high anyway for all the people. So people at this age, how much treatment we have to use to intensify the goals. We will discuss that in coming slides. Why is it important? And again, I want to emphasize that we have to look at the patient as a whole and not only look at one risk factor. For example, for a female 60 years of age, and we are looking at 60 years of age over here. If the cholesterol millimoles is 7 into 4, 280, blood pressure 120, non-smoker, risk is 2%. So even with the cholesterol of 280, risk is 2%. But same person, if the blood pressure goes up to 140 and starts smoking, risk goes up to 5. If a male, even if the cholesterol is on the lower side, but if blood pressure is 160, person is non-smoker, the risk is 9. But if the same person goes and starts smoking, the risk goes up to as much as 21%. So we have to look at the whole patient profile before we start giving them medications. The goals changed in 2019. So previously they were liberal, now they become a little more strict, and I think as the time goes by, perhaps will become stricter. So now for the very high risk patient, people who have got ischemic heart disease or diabetes with risk factors and renal disease, now the goal is 55 milligram or 50% of reduction. For the people with high risk, the goal is 70% or 50% reduction. Moderate risk, 100 milligram per deciliter, and for low risk, it is 115. This becomes very clear when you look at it. So when you've got a low risk less than 1%, your target is 116. If your risk is between 1 to 5 as calculated on the score, your target becomes 100 milligram. And people with high risk, the ones who have got markedly elevated one risk factor or familial history or moderate CKD, the goal is 70 milligram. And those at very high risk, like people with ASVD or high risk score, the goal is 55. So as your risk profile becomes more and more high risky, then your goal also becomes very low. And this is explained very nicely in this chart, that if you look at the risk profile over here on the left side, which is low risk, moderate risk, high risk, and high risk, and very high risk, and you look at the cholesterol LDL levels on this side. So this is 55 to 70, this is 70 to 100, 100 to 116, this is 116 to 190 and above 190. So if you look at the right column, everybody needs treatment. But if you look at the left column, when the cholesterol is so low, nobody needs treatment, they need only lifestyle advice. But looking on this middle part of it, so if somebody has got higher risk as we go down, they start needing lifestyle intervention and may require drug. So at a level of 100 milligram, those who are at a high risk, they definitely require concomitant drug. For a person who has got 100 to 16 and moderate risk, he will start requiring treatment for this risk. So again, the same message: higher the risk, lower the goals and to start, and lower the goals to achieve. And this is the final slide to nail this point home. So if you reduce cholesterol by 1 millimole in people who have got low risk between 5 and 10, you save 170 major cardiovascular events. And if you reduce cholesterol by 2 millimoles, this number almost doubles up, becomes 310. But same cholesterol reduction in people who are at higher risk at 30, you save 730 cardiovascular events. And if you increase, if you reduce their cholesterol by 2 millimoles, then you save 1440. So that explains very nicely. If you reduce cholesterol bit more by 2 millimoles, that's about 80 milligrams, you get more dividends. And if you do that in people who have got higher risk, you get more dividends in those cases as well. So I think this explains very nicely as to when do we start treatment and when do we arrive. So the recommendations by the ESC are that in secondary prevention, patients at very high risk, remember the very high risk, the goal to achieve is 55 milligram or 50% reduction from the baseline. For primary prevention, again, it is the same thing. People who are at a very high risk, you would like to achieve a goal of either 55 milligram or it is less than 50%. People who have got familial hypercholesterolemia and at a heavy risk, so then you would like to achieve the same sort of a goal at 55 milligram. So for primary prevention, for secondary prevention, for familial history of cholesterolemia, again, in all those people who have got, you would like to achieve the goal as low as 55 milligram. For primary, secondary prevention, it is class 1 recommendation, whereas for this, it is class 2A. Now, in people who have had disease before as ASVD and experience a second vascular event, which could be either a CVA or some peripheral artery disease within 2 years, in those people, the goal has been shown to be a little lower. And this is a new recommendation. For this, the goal goes down to 40 milligram. So a person who had an event before and another event within 2 years, the goal goes down to as low as 40 milligram. In patients who are at high risk, the goal is 70 milligram and not 55 milligram. Those who are at moderate risk, the goal is 100 milligram, and those who are at a low risk, the goal is 115 milligram. What do we do in patients with hypertriglyceridemia? In patients who have got hypertriglyceridemia more than 200 milligram, the first drug of choice should be a statin therapy, and this we will discuss in the coming lectures. But if somebody is taking statin and LDL-C goal is already achieved and still have high triglyceride, then fenofibrate or bezafibrate can be used. Or in patients who are at high risk and high with the triglyceride, you can start, which is not available in Pakistan, acosapentyl ethyl. In all these patients, you would like to use high intensity statins up to the highest tolerated dose. So many people will tolerate, some will not tolerate. So in those patients in which you are using high intensity goal and still the goal is not achieved, you would like to use ezetimibe in those patients. And if still the goal is not achieved, then you should know that we can use PCSK9 for these people and we should try to get it from them. Important thing for diabetes is that in patients with type 2 diabetes who are at very high risk, which is people who already have established cardiovascular disease or who have severe TOD, the goal is 55 milligram or 50% reduction in their LDL. And those who have got diabetes less than 40 years, so type 2 diabetes more than 40 years at high risk, the lipid level should be 70 milligram. New recommendation is statin therapy may be considered in persons aged less than 40 years with type 1 diabetes or type 2 diabetes with evidence of target organ damage. So in patients which have got aggressive diabetes, type 1 diabetes or type 2 diabetes, and age is less than 40 years, and they have evidence of target organ damage, the goal should be to achieve 100 milligram. And if this 100 milligram is not achieved, it's statins only, and you will find that very frequently, then you will have to add azithromycin to these people. What is the recommendation for old people? For older people, more than 70 years of age, the risk of coronary artery disease, those who have got established cardiovascular disease, it is the same as for a younger person. But initiation of statin therapy for primary prevention above 70 years of age should be considered if the risk is high or above. That is, risk high or very high risk. And it is recommended that we may consider using a low dosage if there is any evidence of renal impairment. For all these patients, the new recommendation is that we must use a stepwise approach, which means we intensify their therapy slowly, gradually. And this is for people who are apparently healthy, or those who have got cardiovascular disease, or those who have got the risk of cardiovascular disease. And this all should be done, and we will explain that we should look at treatment benefit, risk modifiers, comorbidities, and patient preferences. So everything should be looked at, and we should not go bombing with very high sort of intensity statins. We should have a stepwise treatment approach in these all sort of patients. So this is something new that has come to us, and that is that there are 4 categories of patients when you are confronted in your clinical practice. People who are healthy, and they call us apparently healthy people, those who have got established cardiovascular disease, those who have got type 2 diabetes, and those who have got CKD or familial history. And for these, the prevention goals have been defined. There's a step 1 and there's step 2. What is a step 1? Step 1 is that in all these 4 groups, you look at the prevention goals for all the 4 groups. And then after that, you look at their 10 years cardiovascular risk individually, and you look at the risk modifiers, lifetime risk, treatment benefit, and patient priorities. And you look at everything and decide for further goals. And depending on these things, which is 10 years CVD risk, lifetime CVD risk, comorbidities, then you ultimately establish what is the prevention goal. In all these people, those who are at higher risk, you start them on therapy so as to get blood pressure less than 130 millimeter of mercury and cholesterol around 55 milligram. So if there are people or patients who are at a higher risk, then you try to bring down their blood pressure low and their cholesterol low, and you may even think, of course, they'll be on DAPT or other newer therapy, including thinking of colchicine, which is being recommended now. What about apparently healthy persons? So a person comes to you, he's apparently healthy. So you start with stopping smoking, lifestyle recommendations, and blood pressure has to be brought down below 160. So this is for the first time that European society has brought out recommendations based on age. So less than 50 years of age, between 50 and 70, and above 70 years of age. Is perhaps that we do not see many patients above 70 years of age. So what do we have? So you look at 10 years risk. Below 50, the risk will be either 2.5 or above 7.5. So these are 3 categories of patients. Those who are above between 50 and 70, the risk on the low risk will be 5%. Those in between 5 to 10, and then there are patients above 10% of risk. Again, for those above 70, the lowest risk is 7.5, in between 7.5 to 15, and then it's higher than 15. So in this sort of patient, you try and you've got your goals for you. So blood pressure should be less than 140, preferably 130 in those high risk patients. In this class of patients between 50 and 60, again, you try to have the same sort of goals, blood pressure less than 140 and LDL cholesterol less than 100. But in this group of people, we try to again estimate the goal. Between low risk people, you do not need to do anything additional. But in this group of people in which risk is more than 7.5 and 15, you try to achieve lower blood pressure and lower cholesterol. And in those who have got in the step 2 higher risk, then you try to bring their cholesterol less than 70, and in people who have got very high risk, 55. So even in this sort of a setting, the message is same, that you look, individualize everybody a risk factor. You look at their risk factor, you think about them, and try to get at least blood pressure 140, cholesterol less than 100. And if at this stage you think you can do more for your patient, you continue to do it more and try to bring their cholesterol lower and their blood pressure lower. So this is for apparently healthy people. Now, those who already have cardiovascular disease, what do you do? The first thing is, of course, stop smoking and lifestyle recommendation. Blood pressure less than 140 and if possible less than 130, anti-thrombotic therapy, and cholesterol less than 70 milligram. And those who have got higher risk, you bring their cholesterol as low as 55 and try to continue with that. Similar is the message for people who have got diabetes. So you've got diabetes patients who have got disease without target organ disease and with target organ disease. In all these diabetic patients, we must ask them to stop smoking, lifestyle modification, cholesterol should, HbA1c should be less than 7. So this is standard for that. But then those without risk factors, again, we look at them as a moderate or a high risk factor. So for a moderate, we do not do anything more. For high, try to bring their blood pressure down and try to bring their cholesterol down, blood pressure down to 130 and cholesterol down to 100 milligram. On those big group of patients who already have cardiovascular disease or who have got target organ disease, then your blood pressure should be brought down to 140, 130. LDL brought down to 70. Of course, we should think about anti-thrombotic therapy, and the newer recommendation is SGLT and GLP, and we'll be sharing this in the coming lecture. Now, having reached this stage, you are on the stepping stone to go on to the next stage. So next stage, you consider after calculating 10 years CVD risk, lifetime CVD risk, looking at comorbidities and patient preference, and try to bring their blood pressure lower to 130, cholesterol lower to 70, here blood pressure 130 and cholesterol lower to 55. So here it is 70, it is 55, and consider using SGLT2 inhibitors or GLP-1. Now, this is a very interesting data that has been presented for the first time. This is actually calculates the average years free of cardiovascular disease on reducing cholesterol for 40 milligram above. So if you look at this non-HDL cholesterol, they're not talking about LDL, but non-LDL cholesterol. And if you look at the cholesterol over here, this gives you the number of years that you can save in people like this. So people in whom the cholesterol is high and the age is, and let's look at this group of age, let's say 60 to 64 years of age, you can save in those who've got high blood pressure, same sort of a score, you can save by bringing down cholesterol by 40 milligram, 1.8 years over here, more in non-smokers, less than smokers, and same 1.4 in males and 0.9 in smokers. So it seems we can prolong life theoretically by reducing cholesterol by 40 milligram more in people who are non-smokers and those who are at higher risk. And this data is very interesting. Now, when you have got the targets, and when you start therapy, you must have an idea as to what sort of a therapy do you want to institute and what will be the result. So this is the guideline that if you use moderate intensity statins, the reduction in cholesterol will be about 30%. If you use high intensity statin, it will bring it down by 50%. And if you use high intensity plus ezetimibe, you can bring down your cholesterol as low as by 65%. And you will need such sort of a combination in many of your patients. Look at PCSK9. This is reducing it by 60%, and high intensity plus ezetimibe brings it down by 65%. So PCSK9 plus statins goes down by 75%. And if you really want to bring it down, then PCSK9, high intensity statins plus ezetimibe will bring it down by 85%. So this is an estimate that when you want to institute therapy, what should be your aim. Now, just for general information, when the LDL cholesterol goal is 100, non-HDL, you add 30 more to it. So it is about 130. And apolipoprotein will be 100. If the goal is 70, non-HDL cholesterol will be 100 and apolipoprotein will be 80. If the goal is 55, then non-HDL will be 85 and apolipoprotein will be 65. A few words about the diet and then about the exercise. Most of it revolves around having a healthy diet. So Mediterranean or similar diet should be used to prevent cardiovascular disease. It is recommended to replace saturated with unsaturated or monounsaturated acids to lower the risk of cardiovascular disease. It is recommended to reduce the salt intake for blood pressure and reduction of cardiovascular risk factors, and to choose more plant-based food pattern. So when you come to KPK, we will not offer you thickas over here because we would like to offer you more plant-based food patterns that includes whole grains, fruits, vegetables, pulses, and nuts. And it is recommended that you should eat fish, perhaps preferably fatty fish, at least twice a week, and to restrict sugar-free, free sugar consumption. Do not take any sugar at all, especially do not take any sugar-sweetened beverages as such. So the recommendation is to have a plant-based diet, saturated fatty acid less than 10%, transsaturated fatty acid should be minimized as far as possible, salt intake less than 5, fiber should be taken 30 to 45, 200 grams of fruit per day, 200 grams of vegetable per day. Red meat should be reduced to a maximum of less than 1 kilo per week. That's a bad news for us. And fish is recommended 1 to 2 times per week, and 30 grams of unsalted nuts per day. Consumption of alcohol should be limited, banned, and sugar sweetened beverages such as soft drinks and fruit juices must be discouraged. And this is a very nice slide to show that if you use trans fat, it actually increases your risk of having cardiovascular disease. If you use monounsaturated fatty acid, monounsaturated, which are like olive oil, peanut oil, avocados, canola oil, almonds, or hazelnuts, it reduces your risk by about 5%, by about 12%. But if you use polyunsaturated fatty acids like walnuts, sunflowers, flaxseed, fish, salmon, tuna, trout, corn oil, this reduces it much further by about 25%. Carbohydrates from refined sugar increases the risk, and carbohydrates from whole grains does not increase the risk, it improves the risk. So a healthy plate will look like that at least one half of it is vegetables, only 1/4 of a portion has got a starch, and 1 portion of it has got proteins in it. And coming on to now exercise. Exercise, it is recommended that for all adults to try to have at least 150 to 300 minutes per week of moderate exercise, or 75 to 150 minutes a week of vigorous exercise. So 150 will be 30 minutes every day for 5 days, or perhaps 60 minutes every day for 5 days. That is what is required by this thing. It is also recommended that adults who cannot perform 150 minutes of moderate intensity exercise a week should stay as active as their abilities and health conditions allow. So some people are handicapped in some ways. We should still try to encourage them to exercise as much as possible. We should recommend to reduce sedentary time, to engage in at least light activity throughout the day to reduce all-cause cardiovascular mortality and morbidity. And the new recommendation is that we must perform resistance exercise, so sort of weightlifting sort of a thing, in addition to aerobic activity, and this should be at least 2 or more days per week. So at least twice or thrice a week, we should also include resistance exercise in our routine. Lifestyle interventions such as group or individual exercise, are very much recommended. And this also encourages to use and use activity trackers like mobiles, so you can give targets to your patients that so many steps you have to walk, so much exercise you have to do, and so much calories you have to burn. Just to give you a rough idea, light exercise is like walking about 4.7 kilometer per hour, and that will burn about 1.1 to about 2.9 MET. Moderate exercise is when breathing is faster but compatible with speaking with full sentences. So this is when you walk at the speed between 4 and 6 kilometers. So this is the least one can do. And of course, vigorous exercise, as Bashir Hanif cycles every weekend, that is like breathing very hard, incompatible with carrying on a conversation. So you would be recommending to our patients to walk as fast as possible, perhaps to the limit where they exercise, where they cannot talk. So just to conclude what I've said before, is that the major risks for cardiovascular disease are, of course, cholesterol, blood pressure, cigarette smoking, diabetes, adiposity. For all these risk factors, not only for cholesterol, a stepwise approach is recommended to reduce the ultimate treatment goals in all the groups of people, whether they are apparently healthy or those who have got established cardiovascular disease or those who are diabetes. And those who have got cardiovascular disease, it is estimated from 40 to 69 by score, and the other one is score OP card. Age-specific 10 years cardiovascular risk thresholds together, we should be estimating with risk modifiers, which I'm going to take in a minute, frailty, comorbidities, lifetime cardiovascular risk, and treatment benefit. What it means is that when you have a patient who has been treated and has a cholesterol LDL of, let's say, 70, and you want to go a step further, how do you go a step further? One important point is you should be reflecting on what you are practicing. And secondly, you look at all these risk factors and then decide to go if you have to go a step further. What are the risk modifiers? And this is something that we do not take into account because these are the softest sort of things. Psychological stress. Some risk scores may over or underestimate. And a new thing which has come up, which we must be following more rigorously, is calcium scoring. Calcium scoring is the best established imaging modality which improves CVD risk stratification. So if it's less than 5, it's okay. Between 5 and 20, moderate. Anything more than 20 is supposed to be harboring cardiovascular disease and should be treated more aggressively. Frailty is a functional risk factor for both cardiovascular and non-cardiovascular morbidity. Family history should be inquired about routinely, and those who've got a positive family history, they should be attacked more aggressively. Genomic risk factors are not being recommended at present time. Social gradients do affect cardiovascular disease, so you should be thinking beyond whatever it is for people who are a little more compromised in their resources. Air pollution is very strongly associated with cardiovascular disease, and there is a lot of things taking place for that. Urine biomarkers and circulating biomarkers should not be routinely measured at present. Maybe they become at present in the future something that we should be looking forward to. And in those people who have got obesity, we should look for cardiovascular risk disease. So out of this, important thing is that calcium scoring is something we should be doing in our patients to look for the risk of cardiovascular disease. And my last two slides, we realize LDL, the lower is better. And when we say LDL lower is better, we look at both the baseline and the total duration of exposure to lower cholesterol. If LDL is not lowered with just statins, think of ezetimibe and PCSK9. And also a very important message that we should take home. Sometimes you will find out that it is almost very difficult or impossible with our armamentarium that we have, that you cannot achieve your LDL goals. So if you cannot achieve your LDL goal, at least aim to reduce your LDL by 50%, and then strive to reduce other risk factors like blood pressure, like exercise, like make sure that they give up smoking. So this is something important for our patients. To conclude, for all our patients, we should do a risk determination, dividing them into a very high, moderate, and low risk. The four populations that we come across: apparently healthy, cardiovascular disease, diabetes, and CKD, it almost fits in very nicely that for very high risk, you should set the goal as 55, for high 70, for moderate 100, and for low 115. Those who have recurrence on high statin dose, the target should be 40. We should use a stepwise approach and intensify and always keep on thinking about how to improve the patient risk profile. And I've started share some guidelines for the diet and for exercise. Now the time goes back. So we go to our questions again that I posted before, and now these questions, and I want their answer. We are not doing any polls, so you please make up your mind about the answers, and I will show you the answer in a minute. And the answer here is number 2, 55 milligram.
Hafiz, it's a great lecture. If I may comment, when you say 55, based on the slides you've just shown, can you give the reference that there's 55 and not 70 on account of multiple risk factors?
Okay, I thought I will sort of let a panel of experts talk about it. Okay, in this group of patients, this patient already has established ischemic heart disease. So this is, of course, a patient who has got very high risk score. This patient who have got one risk factor, which is very high, and here the target will be 70 milligram. Question 3. So answer is 55 milligram. Why? This patient already had a PCI. So history of PCI puts him in a very high risk score. So even if his LDL, total cholesterol is not too high, but the risk LDL is very high. So we must bring it down to 55. Here, the answer is 40. Why? She had an MI before and she had a CVA this time. So MI and CVA, though it's a little more than 4 years, but still the aim over here would be to bring it down as low as 40 milligram. The original recommendation is within 2 years. Here I've stretched it to 4 years. Why? Because this is a diabetic, more than 20 years of duration, has a three risk factors, hypertension, male, and smokes more than 10 cigarettes, and also evidence of target organ damage. So in this patient, the target for LDL will be 55. Longer duration of diabetes, presence of other additional risk factors, and also having evidence of target organ damage. So this diabetic needs to bring it down to 55. Last question. Here the answer is 55. Why? Because this lady who's hypertensive, she had a right-sided stroke. So whether it was a history of acute MI or a history of stroke, these patients qualify for very high risk. And these patients should be put on a cholesterol therapy, which should bring it down by less than 55 milligram.
Hafiz, can I just point out there that just the CVA should be qualified as ischemic?
Yes.
It may not, because you can also have a hemorrhage in hypertension.
Yes. So we have got two very illustrious colleagues of mine who have agreed to be panelists. Dr. Tahir Saghir from NICVD, who is a wonderful interventionalist and secretary of our Pakistan Cardiac Society of Intervention. He is joined us from Karachi, and Professor Mahmood Al Hassan, Professor of Interventional Cardiology from HMC and the convener for the coming cardiology conference. So can I request Tahir Saghir for some comments?
Before the comments, I would like to ask Professor, first of all, it's a very comprehensive and a good teaching session organized by Hafizullah Sahab, and a very good and elaborate and simplified approach to the patients with the dyslipidemia and also the management plan. I would like to ask Professor Hafizullah, it's a very common question, how frequently we should do the lipid profile, initial and follow-up?
I think it depends upon your cholesterol level. If your cholesterol level is high, you start doing it on a sort of a monthly to 2 monthly basis. And so once it is stabilized, then perhaps quarterly, every 3 months is something that you should be doing and keeping an eye. The other, I think an eye opener for most of us will be if you just start looking at LDL and forget about the rest of. So if you target only LDL, a new world will unveil on you that people whom you thought were controlled based on just cholesterol, they will be presenting you new targets. And you will also find it very difficult to achieve the targets of 70 or 55 on statins or statins plus ezetimibe.
Can I make a comment, sir?
Sir.
Yes, sir.
I think this level of cholesterol is very, as you can see, like in hypertension, the levels are coming down, and they will keep coming down. And I think it is a very wonderful lecture that you gave. In our society, I think family history is a very important factor which I come across, and that's something which should really be further elaborated. And for these people, my tendency to they bring the LDL down to much lower. Regarding the question of how frequent should you do the LDL, there's not a concept that you label a person into a group and then you titrate the dose according to the risk factor. And once you give him that dosage, you stick with that dosage, and by and large, this would bring the LDL down to 50% or whatever. It may or may not touch 55, but a lot of people do cholesterol levels. I think doing it very frequently is probably not fair. Once I've seen a level come down, I'd probably not recommend doing it more than once a year. And lots of people feel that you just do the cholesterol level numbers to see if the patient's compliant or not. Because if you, for example, if you reached a full dosage, let's say you're giving a 20 milligram ezetimibe, 10 milligram ezetimibe, and 20 milligram of rosuvastatin. Now that is a very mega dosage. And so if you're giving that mega dosage, then you'd be pretty close to 55. You should probably accept that. That's just one concept. But these numbers, of course, are very universal and they have to be followed. But there's one concept that give that mega dosage, do the lipid level once a year to see if the patient is compliant or not, and then see the trend rather than a particular number every time.
Right. Can I ask Mahmood Al Hassan, our panelist, to please? Yeah.
Yes, sir. I agree with the Professor Suhail Aziz about the recommendation, how frequent we should do the level of cholesterol and monitor. The guideline is very strict about it. They say you should do after every 6 weeks, but it's very difficult and cumbersome for the patient. But initially, I think we should stick to the goals according to the guidelines, not only for the level of the cholesterol measurement, but also to look for the side effects of the statin therapy. This is very important for them to look, because if you, in our population, if you give even 10 milligram, the patient usually develop myalgias and they come with you that I have body aches and muscle pain. So in society, in our society, it's very difficult to do cholesterol frequently after 2 months or after 3 months. We should have our own guidelines and recommendation for doing cholesterol and managing their levels on our own basis?
Can I ask Professor Hafizullah one question? As we all know that in Asian population, the plasma level of rosuvastatin is on higher side. So in high intensity treatment, should we go for the 40 or 20 milligram rosuvastatin, or we start with the 10 milligram in high intensity therapy?
I think in high intensity, they recommend 20 milligram for high intensity, and for low intensity is 10 milligram. So in people who can tolerate, I think you can escalate from 10 to 20 milligram. And if you can achieve your levels, you should persist with that. And if your patient is showing some side effects, it may be a good idea to reduce from 20 to 10 and add azithromycin to it, because azithromycin by and large that we know of do not cause any side effects. So now I see my practice shifting to using of more of azithromycin, 10 milligram of rosuvastatin plus 10 milligram of azithromycin. I think this question of doing cholesterol once a year is perhaps not correct. The reason being that cholesterol, if you check it and then if you leave it, most patients, because they do not have any symptoms from cholesterol, so they will slowly, gradually stop the dose and stop taking it or reduce the dose. So unless we check it, I mean, if you just ask patient, "Aap dawai kha rahe?" "Haan ji, hum kha rahe." Unless you check and you confirm that your cholesterol has gone up, so perhaps you're not taking your drugs. So it is perhaps recommended that whenever patients come to see you, not less than quarterly, but it should be something like quarterly that we see our patients, or 6 monthly, we must check up their cholesterol to, as put in very nicely, to look at their compliance and also to make sure that the goals are being achieved, because we will get only the benefit only when the goals are being achieved. So it is recommended that we check it out. Somebody has asked a question, and I may answer the question over here. How do we get coronary calcium score? The way we get coronary calcium score is by doing CT angio without giving the dye. So the CT angiography without any dye, they can look at the calcium which is deposited in coronary arteries. So if it is less than 5, it means it's a very low risk. Between 5 and 20, it's a moderate risk. And if it is more than 20, then it is a very high risk. So that means those patients should receive intensive, even if they are inverted commas apparently healthy, they should receive intense medical therapy, bringing down their blood pressure, bringing down their cholesterol, and also making sure that they exercise regularly and stop smoking.
Having said that, Dr. Professor Hafizullah, it's a very wonderful guideline to follow. But this is actually a European data where this disease tends to appear much later in life. We in AFIC have shown in a paper that you can have zero cholesterol and yet have critical disease. We've come across these patients. So if the patient is symptomatic, then having a zero score probably means nothing. Then you need to go ahead and do something else based on functional test or whatever is the clinical scenario. But by and large, this score of grading calcium is very universal. But I think in our population, where the disease comes in much earlier, calcium score is less predictable of severity of disease. I've seen very low score and critical disease, and this probably is more extrapolation of the Western data than our own population.
No, I think these are anecdotes when you may have a zero calcium and you may have disease. It's like saying somebody had an acute MI with a cholesterol of 180 and LDL of 80. Yes, that is possible. But by and large, the guidelines are that if your calcium scoring is low, there is less tendency of developing problems, and there is people who will have a calcium score as high as 100, and they may not have any critical disease. So these are the guidelines which are applicable to the general population by and large, applicable to people in America, in Europe, similarly as the guidelines are applicable to America, Europe, and over here as well.
I have one query about this role of CRP and level of cholesterol. any role of CRP and treating target levels.
So which trial you're referring to?
Jupiter.
There is a
trial?
there's a highly sensitive
So
CRP
there is,
which is
yeah,
a predictor of acute syndrome,
HSCRP.
not the usual CRP.
Exactly. So HSCRP has been shown to go down with rosuvastatin, and that is a very nice study which showed that it not only reduces cholesterol, it also reduces your HSCRP. But that's such an expensive sort of a tool, which probably does not give you any further information. So it is best to stick around with your cholesterol and try to bring down cholesterol down. But something interesting that I would like all cardiologists, I will urge all cardiologists to look at LDL more critically after this presentation, and they will find out that, you know, this is a different sort of a ball game altogether. Up till now, our teaching had been traditional to look at cholesterol and then partially cast an eye on LDL. Now, no, if you just focus your eyes only on LDL, perhaps only get LDL done on your patients, because by and large, triglyceride is not very helpful because most patients are not fasting. So you look at LDL, and then a new world will dawn upon you, and you will find out how many patients need further intensification of their treatment based on this, and they would need to get better control based on this. And again, you will be seeing that there is, in spite of all your efforts, in spite of dietary therapy, in spite of exercise, it is difficult to achieve these goals, but one must strive to achieve these goals for as much as possible in these patients.
Hafizullah Saab, I couldn't agree more with you. I think when you advise tests nowadays, I tend to, just say write LDL, because triglyceride, of course, is a risk factor, but it has a weaker link. And whatever the triglyceride level, you can do it once, but then I just follow the LDL. I think there's a little motive for the lab people to do the spectrum, because I think they tend to then charge more. Similarly, if I write urea and electrolytes, I find labs doing chlorides and so on and so forth, and all the other electrolytes, which probably do not help me as, and uric acids, which do not probably help me in my management of my patients. So now I think it's much important to write exactly what you want. You want potassium, you want creatinine, because labs have their own ulterior motives. So if you are a little vague in your description, they will write an extensive spectrum of tests and charge more. I think we are a lawyer not only for everybody, to present the interest of the patient also, and his costing and his cost implications are a part of our a responsibility to make sure that we look after that aspect also. So when we advise these tests, I think we should work out what is a reasonable expense for in his interest. So that's why I think the question of how frequently should you do these tests, and I think if you motivate the patient enough, they will follow your treatment. Similarly, for cramps and aches and pains, I used to see a lot of them initially, but for some reason, lately my patients have stopped complaining a lot about aches and pains. Very few, and it's probably because I tend to emphasize a little more on this and tell them about the vague relationship and anecdotal and old wives' tales about aches and pains. Of course, they are there, but the question is, what are different remedies one can apply if somebody has aches and pains? I think one to me is a good motivational, counseling would go a long way in relieving his aches and pains and make him get over it. I tend to give them little, paracetamol or that kind of aches and pain kind of medicine. Tell them physical activity, build up some muscle, do more physical activity. That I think helps. My question being, how many of you think that Q10 is a useful drug to have in your armamentarium? There's a lot of promotion about it. I've tried to read it. The literature says it has some benefit. Now, what is your experience, and how often should you does one use these Q10? Is it really an alternate medicine, or you think there's something more to it?
I
have
think
no sir,
जी ताहिर आप बोलें
नहीं आप please नहीं please आप
नहीं
please
I want to do
sir.
something conclusion. I want to do some concluding remarks.
अच्छा मैं अपना एक्सपीरियंस बता सकता हूँ. मैं Q10 का तो मेरा एक्सपीरियंस नहीं. I haven't any experience of Q10. I didn't know that. Other thing is that I usually, if after counseling patient is still complaining of aches and pains, I usually stop the drug for 7 days, a week, and just ask them about their symptoms. If the symptoms improve, maybe we can, I usually reduce the dose and restart. If again pain, then I usually switch to ezetimibe.
Right. I think the time is over. I think we had a wonderful discussion, and this Saturday morning sessions are going in a great style on the forum of Academic Council of Pakistan Cardiac Society under the leadership of Suhail Aziz. So I think this is a wonderful. The next session will be on talks on ECG. So we would like all of you to clock in once again at 9:30. After that, we will have another lecture on dyslipidemia, and that will be by Bashir Hanif. And that is when we will be discussing statins and also the side effects of statins. So this question will be addressed, inshallah, next time in greater details. So please don't forget your questions. We'll be asking these questions next time. Till next week, that is a very after prayers for the people who departed yesterday in the gory sort of a bomb blast. I say goodbye to all of you.